Hello everyone and welcome to the daily quiz series, and we are in day 3 of general physiology and muscle physiology. The quiz is available on my Telegram channel, which you can attempt before seeing this video. So let's look at the first question. This says, which of the following will cause a decrease in the ECF potassium? Now, please remember that there is a sodium-potassium ATPase pump which pumps out 3 sodium and brings in 2 potassium. So if I increase the activity of the sodium-potassium ATPase pump, it will cause the potassium to move from ECF to ICF. So what will happen to the ECF potassium? Reduces. You know that the normal potassium levels in the ECF is very, very low. It is about 3.5 to 5 millimoles per liter, or which can also be written as milliequivalents per liter. For univalent ions, moles and equivalents are the same. So if I increase the activity of the sodium-potassium ATPase, I will reduce the ECF potassium. Now, there are a number of hormones which can affect the sodium-potassium ATPase pump. So let's take the first one. The first one is thyroid. Thyroid will increase the number of the sodium-potassium ATPase pumps. The thyroid hormones will increase the synthesis of these pumps. They increase the number. Aldosterone has a dual action. It not only causes synthesis of more sodium-potassium ATPase pumps, but it also increases the activity of the individual sodium-potassium ATPase pumps. Insulin. This will increase the activity without affecting the number. You know that one of the treatments of hyperkalemia is to give insulin. Insulin will increase the activity of the sodium-potassium ATPase pumps. Potassium will move intracellularly and hyperkalemia will be corrected. But of course, if you are giving the patient insulin, you will also have to give dextrose because you're also causing a hypoglycemia in the patient. Epinephrine. Epinephrine also increases the activity of the sodium-potassium ATPase pump. Dopamine and ANP. These are 2 hormones, atrial natriuretic peptide. They will reduce the pump activity. So the answer here out of all these is going to be epinephrine. Epinephrine increases pump activity, causes potassium to move into the cells, and decreases the ECF potassium. Let's have a look at the next question. Now, which is this type of signaling which is shown in the figure? Now, here is a cell whose secretions are acting on a neighboring cell. The target cell here, this is the target cell. The receptors are on the target cell, and the signaling cell releases its secretion or the signaling molecule which acts on receptors on the target cell. This is definitely not autocrine. Autocrine is where the target cell is the same cell. Same as the target cell is the same cell. Same as the secreting cell or the signaling cell. Receptors are on the same cell. So this is definitely not the answer. Juxtacrine. Remember J in juxtacrine, J in adjacent. So the target cell in juxtacrine is the adjacent cell. The cell which is right next to each other. Paracrine, the target cell is a neighboring cell. And endocrine is where the target cell is a distant cell and the secretion now travels through the blood vessels to reach the target cell at a distance. That is endocrine. So out of these, your best answer here becomes paracrine. That means it is a neighboring cell. Please remember, why is this not juxtacrine? Juxtacrine would have been right absolutely the adjacent cell. So that means they're right next to each other. Then it would have been a juxtacrine. This is at a distance away, but in the neighborhood, so it becomes paracrine. Had there been a blood vessel here, that means the secretion reaches the target cell via blood vessel, then we would have said it is a endocrine secretion. The blood vessel would be something like this, right? And reaching the target cell, then it would be endocrine. Let's have a look at the next question. It says, 65-year-old man with chronic renal failure on dialysis presents with generalized fatigue and occasional palpitations. On examination, his pulse is irregular. ECG reveals tall tented T waves. Tall tented T waves are typically seen in hyperkalemia. There is a prolonged PR interval as well, again, pointing towards hyperkalemia with widened QRS. Which of the following is the physiological basis of this patient's condition? So this is a very typical kind of a question which is asked in the NEETPG, where you're given a clinical situation. So you not only have to diagnose what is the condition, like you've been given hints here, and then explain the physiological basis. So this says, is it an increased resting membrane potential? Is it a reduced membrane excitability due to sustained depolarization, inactivation of sodium channels, or is it increased repolarization speed or a decreased threshold potential? So let's try and figure this out. Now, I would like to discuss what is the effect of hypokalemia and hyperkalemia on the resting membrane potential and therefore the excitability. See, you know that it is the diffusion of potassium which is responsible for the resting membrane potential, isn't it? Potassium is more inside the cell, less outside. At rest, the membrane is maximally permeable to potassium. So potassium tends to go from inside to out, creating a negative potential inside the cell. That is the main reason for the resting membrane potential, for a negative resting membrane potential. Now, what happens if there is a hypokalemia? Now, we know that the potassium inside the cell is approximately 140 millimoles per liter, and outside the cell is 3.5 to 5. So let's say the outside potassium reduces to 2. Severe hypokalemia. So what happens if there is a hypokalemia? Now, what has happened to the gradient? There is now an increase in the concentration gradient. Gradient would refer to the difference between the potassium inside and outside the cell. There is increase in the concentration gradient for potassium. This causes an increase in the diffusion potential of potassium. That means now there is an increased tendency of potassium to leave the cell. If you have more positive charge leaving the cell, that means a more negative potential inside. So this causes a more negative membrane potential. That means where the resting membrane potential is minus 70 millivolts for most neurons, now probably it becomes even more negative because more potassium has gone out of the cell. So it may be minus 80, minus 85 millivolts, right? So that means when it becomes a more negative potential, we call it a hyperpolarization. Now, why do we call it a hyperpolarization? Because you must remember, when the cell is hyperpolarized, there is an increase in potential. Why do I call it an increase in potential? Potential is changed from minus 70 to minus 80. Please remember, the potential has increased from 70 to 80 millivolts. The minus sign has no mathematical significance. Minus sign only tells you that the inside is negative with respect to outside. So potential has increased. That is why it's called hyperpolarization. And what will happen to the excitability? Excitability will be reduced. It is difficult to excite the cell. It is now I need a stronger stimulus to take the potential of the cell from RMP to threshold. Have you got my point? And one of the important symptoms in a patient of hypokalemia is a muscle weakness. Why muscle weakness? Because neurons and muscles, these are the two excitable cells in the body. Now, these are hyperpolarized. The excitability is less. So it results in muscle weakness. Now, let's try and see what happens in a hyperkalemia. Now, absolutely the reverse. Now, outside potassium has increased. Maybe it has become 5.5 or 6, right? So what will happen? Now there is a decrease in the concentration gradient for potassium. So there is less potassium which leaves the cell. There is a decrease in the diffusion potential of potassium. That means less tendency of potassium to leave the cell. That means more positive charge inside. So what will happen is that the membrane potential becomes less negative. So instead of being minus 70 millivolts, it may be now minus 60 or minus 65 millivolts. So that means now the cell is depolarized. There is a depolarization which has happened. Now, this depolarization means that the potential has decreased, right? That is why decreased polarization. But excitability has increased. So one of the commonest complications in patients of hyperkalemia is arrhythmias. But this is what you see whenever there is a mild to moderate hyperkalemia. Severe hyperkalemia, the picture changes slightly. Let's try and see what happens. In a severe hyperkalemia, there is a slight difference. Now, the first point is, what is a severe hyperkalemia? Now, we do not have, when do I call hyperkalemia mild to moderate and when do I call it severe? Now, there is no true cutoff figure which is given. I mean, all books talk about it differently. What is severe hyperkalemia? The diagnosis is more clinical, based on the symptoms of the patient, the ECG findings. We call it mild or severe, mild to moderate or severe. But generally speaking, a potassium which is more than 7 or maybe 8 millimoles per liter will be termed as a severe hyperkalemia. Now, what happens in a severe hyperkalemia is, yes, the concentration gradient reduces. Yes, there is less tendency of potassium to leave the cell. But now the cells go into what is known as a persistent depolarization state. Persistent depolarization. Now, what is persistent depolarization? Cells are depolarized. That means potential is less negative. But now they are in what is known as a persistent depolarization state. And during this state, the sodium channels get affected. So in this state, now the sodium channels go into an inactivated state. And please remember, whenever the sodium channel is in the inactivated state, it is impossible to open this channel again. It is impossible to excite the cell again. So if the sodium channels are in the inactivated state, there is a paradoxical decrease in excitability. Cell is depolarized, but there is a reduction in excitability. Please remember, mild to moderate hyperkalemia, cell is depolarized, increased excitability, arrhythmias. But in a severe hyperkalemia, yes, cells are depolarized, but they are now in a persistent depolarization state, which causes a paradoxical decrease in excitability. If there is a decrease in excitability, there is also a decrease in contractility. So what happens now? Now the systoles of the heart will become weaker and weaker. Right? If there is reduced excitability, reduced contractility, systoles start becoming weaker and weaker. The heart dilates. One of the differential diagnoses of a dilated heart is severe hyperkalemia. Systoles will tend to become weaker and weaker. The heart tends to dilate. And this heart eventually stops in diastole. This reduction in excitability explains the prolonged QRS, the widened QRS, the prolonged, the PR interval. This severe hyperkalemia explains why there is a dilated heart and why this heart stops in diastole. So going back to my question here, in hyperkalemia, what do we expect? Is it an increased resting membrane potential? Increased resting membrane potential is a hyperpolarization, which we see in a hypokalemia. So this is not the answer. Is it a reduced membrane excitability due to sustained depolarization and inactivation of sodium channels? Yes, this is seen in severe hyperkalemia. Is it increased repolarization speed? No. Is it decreased threshold potential? No. So answer here is B. Let's have a look at the next question. The cardiac stroke volume depends on the end diastolic volume. This is best represented by which of the following? Is it length force, length tension, length velocity, load velocity? So this is the length tension relationship, also known as the Frank-Starling's law. Now, in the length tension relationship, we take the initial length on the x-axis, and the tension generated is taken on the y-axis. What is initial length? Length of the muscle before it begins to contract. And what is the length tension relationship? It says more the initial length, more is the tension generated, but up to a physiological limit, beyond which further increase in initial length decreases the tension generated. So in the case of the heart, in case of the ventricles, the muscle fibers are circular. What can increase the initial length of the ventricular muscle fibers? If I increase the venous return, if I increase the filling. And diastole is a period of filling. So more the filling, more the end diastolic volume. What will happen to the initial length? More will be the initial length. More will be the tension generated. More the tension generated, more will be the stroke volume, more will be the cardiac output, but up to a physiological limit, beyond which further increase in initial length decreases the cardiac output. See, that is why we can explain what happens in a patient of dilated cardiomyopathy. The initial length is very large, but the tension generated in this heart is less. Why? Because it has now gone beyond the physiological limit. So this is the length-tension relationship. Now, just a brief look at what is load-velocity relationship. So if I take afterload on the x-axis and the velocity of contraction on the y-axis, now it makes a lot of sense that more the afterload, less will be the velocity of contraction. Isn't it? For example, let's say there is a weight which is lying on the ground and you're trying to lift it. Heavier this weight on the ground, less will be your velocity of contraction. Isn't it? So the kind of graph that I get is something like this. Less the afterload, more the velocity, more the afterload, less the velocity. This is what is known as Vmax. And when do I get a Vmax? When the afterload is 0. When there is no afterload, I get a maximum velocity. If I keep increasing the afterload, the velocity will reduce. Right? At this point where the afterload is very high, velocity is 0. I am not able to lift that weight. Yes, there is no change in length here. So, two important points here. This is the load-velocity relationship. When do I get a maximum velocity of contraction when the afterload is 0. When velocity is 0, that means there is no change in length of the muscle. It becomes an isometric contraction. That means there is no change in length, but there will be an increase in the tension. So this is load-velocity relationship. So 2 important relationships I've discussed with you. Length tension, where we discuss the effect of end diastolic volume on the initial length. And the second one I've discussed with you is load-velocity relationship. Next question, what is infinite gain? So please understand, what is gain? Gain, the formula for gain is, this is the correction over the error. This is applicable to negative feedback mechanisms. No feedback mechanism is 100% effective. It corrects the change in the change in the initiating stimulus, and there is always also an error because it is not 100% effective. So there is something known as a gain, correction over the error. When do I get an infinite gain? When the error is 0. Then the gain will be infinite. If this is 0, anything divided by 0 is infinite, infinity. So there most negative feedback mechanisms have a gain, except one which has got an infinite gain where the error is 0, and that is the control of the arterial pressure by the renal body fluid mechanisms. The kidney will do 100% correction to restore the ECF volume and therefore control blood pressure. So renal body fluid mechanisms, control of arterial pressure by renal body fluid mechanisms has a 0 error and an infinite gain.